Welcome to the Anesthesia and Perioperative Medicine channel. Today, we're diving deep into a piece of technology that tries to solve one of the biggest challenges we face in the OR, the ClearSight system. Now, it makes a pretty big promise: continuous, non-invasive hemodynamic data. But the real question is, does it actually deliver? We're going to investigate exactly how it works, we'll scrutinize the accuracy data, and figure out its true place in our day-to-day clinical practice. So let's get started. Here's how we're going to break it all down today. First, we'll set the stage by talking about the perioperative monitoring dilemma we all know so well. Then, we'll get properly introduced to the ClearSight system and its core technology. Section 3, and this is really the heart of it, is where we'll decode the evidence on its accuracy. After that, we'll see how it stacks up in real-world clinical practice. And finally, we'll deliver our verdict on its role and, just as importantly, its limitations. All right, let's kick things off with a challenge that is, well, intimately familiar to all of us. You know, in any high-risk surgery, whether it's a major cardiac case or you're on alert for a postpartum hemorrhage in obstetrics, we live and die by our ability to see hemodynamic changes the second they happen. The real dilemma has always been this: how do we get that critical, continuous, beat-to-beat data without introducing unnecessary risks or delays for our patient? And this dilemma really comes down to our two traditional choices. On one hand, you've got our gold standard, the invasive arterial catheter. I mean, we all love that beautiful continuous waveform. It's what we trust. But let's be honest about the true cost. It can take a surprisingly long time to place, right? Sometimes up to 45 minutes if you're having a tough time. It takes a high level of skill, and it is definitely not risk-free. We're talking about potential vascular injury, thrombosis, local infections, bleeding. And that's not even mentioning the patient's discomfort. Then, on the other hand, you have the standard non-invasive cuff. It's safe, it's easy, no question. But what does it give us? Snapshots, little pictures in time. With a cycle time of every 3, maybe 5 minutes, a catastrophic amount can happen in between those readings. A patient can become profoundly hypotensive, and you might be flying blind for several crucial minutes. This right here, this is the clinical gap that a technology like ClearSight is trying to fill. So that brings us right to the ClearSight system. What it's proposing is basically a third path. It's aiming to give us the continuous, rich data of an A-line, but with the safety and the sheer simplicity of a non-invasive cuff. Now, that's a really ambitious goal, so let's pull back the curtain and see exactly how it claims to do it. The technology at the core of this is actually brilliantly clever. It's called the volume clamp method. So inside that little finger cuff, you've got a photoplethysmograph, basically an infrared light and a sensor. This sensor is constantly measuring the volume of the digital artery by seeing how much light gets absorbed by the red blood cells passing through. Now here's the magic trick. The system's computer works in a super fast feedback loop. As the heart beats and tries to expand the artery, the bladder in the cuff instantly inflates with just enough pressure to stop it from expanding. It literally clamps the volume, keeping the artery's diameter perfectly constant. And here's the crucial insight. The amount of external pressure needed to keep that artery from changing size is, by definition, equal to the pressure inside the artery. So what you get is a direct physical measurement of the arterial pressure waveform, just derived completely from the outside. And when it comes to setup, well, it's a completely different world from placing an A-line. It really is a simple 3-step process. First, you just pop in the patient's height, weight, and age into the monitor. Second, you pick the right size finger cuff, this is important, and apply it to the middle part of the finger. And third, you place the heart reference sensor at the level of the right atrium and you zero the system. Now, that sensor is key because it automatically adjusts for any hydrostatic pressure changes, say if the patient's arm moves up or down. The whole process, from the moment you decide to use it to getting a continuous waveform, takes about 1 to 2 minutes. That speed is a massive operational advantage, especially when every second counts. But here's what really elevates the ClearSight system. It gives you so much more than just a blood pressure number. Because it's capturing the full, high-fidelity arterial waveform, it can analyze it to unlock a whole suite of advanced hemodynamic parameters. You get continuous cardiac output and stroke volume. You also get stroke volume variation, or SVV, which is absolutely critical for guiding our fluid management decisions. And on top of all that, it even calculates systemic vascular resistance. So you see, this transforms it from being just a fancy blood pressure monitor into a comprehensive hemodynamic platform. It's giving you a real-time window into cardiac function, fluid status, and vascular tone, all from a simple cuff on the finger. Okay, so the technology sounds impressive, and the setup is undeniably fast. But as we all know, none of that matters one bit if the numbers it gives us aren't reliable. So this brings us to what I think is the most important section for any of us as practicing clinicians, taking a really rigorous look at the evidence. Does this device actually stand up to scrutiny when you put it head-to-head with our gold standards? This is it. This is the single most important question, isn't it? Can I trust the data that this machine is giving me to make critical, sometimes life-or-death clinical decisions? To really answer that, we first have to get comfortable with the language of validation studies, the statistical tools that researchers use to see how well two different measurement methods agree. The first and most common tool you're going to see everywhere is the Bland-Altman analysis. Think of it as a graphical way to see how well two devices agree. For every single simultaneous measurement you take from ClearSight and an A-line, you just calculate the difference between them. The plot then shows all of those differences against the average of the two measurements, and from this we get two really critical numbers. The first is bias. That's just the average difference. So a bias of plus 2 millimeters of mercury means that on average, ClearSight reads just a little bit higher than the A-line. You want this number to be as close to 0 as possible. The second number is the limits of agreement. This is the range where 95% of all the differences are expected to fall. The narrower this range, the tighter the agreement, and the more confident you can be in the new device. Now let's quickly cover two other important concepts. First up is percentage error, or PE. This helps us answer a really practical question. Are these two devices close enough that I can use them interchangeably? The general consensus, based on the work of Critchley and Critchley, is that a percentage error under 30% is the benchmark for saying, yes, these are clinically interchangeable. Second, we have something called error grid analysis. This is even more practical. It asks, okay, even if the numbers are a bit different, would that difference ever cause me to make a bad clinical decision? It plots the new device against the gold standard and divides the graph into zones of risk. What you want to see is that almost all of the measurements fall into the no-risk or low-risk zones. So let's look at a real-world example to make this concrete. This is a Bland-Altman plot for mean blood pressure from that Masugi study in high-risk OB patients. See that solid line in the middle? That's the bias. It's at minus 2.7 millimeters of mercury. What that tells us is that on average, the ClearSight measured just 2.7 mmHg lower than the invasive arterial line. That is a very, very small systematic difference. Now look at the two dashed lines. Those are your limits of agreement. You can see they run from about plus 12.8 down to minus 18.3. So this tells us that for any single measurement, we can be 95% confident that the ClearSight reading will be within this range of the true invasive value. And this table really summarizes the story the evidence tells across several key studies in different populations. In elderly TAVR patients, Yahaji and Sasaki found a clinically acceptable agreement for MAP with a percentage error of 22.6%, well below that 30% threshold. In those high-risk C-sections, Mizugi and colleagues showed that ClearSight actually met the very strict AMI engineering standards. And for cardiac output in cardiac surgery, Wang and his team found the device to be interchangeable with the gold standard. But, and this is important, the picture isn't perfect. Another study by Gonshin, also in cardiac surgery, found that while the bias for MAP was excellent, almost 0, the limits of agreement were just too wide to satisfy those AMI criteria. So what this tells us is that the evidence is generally quite strong, but there is some variation we need to be aware of. Okay, so with that statistical foundation firmly in place, let's make the leap from the data on the page to the patient at the bedside. How does this technology actually perform in the dynamic, messy, real-world environment of the operating room? Let's look at two very different but equally demanding clinical scenarios. Our first case study is from that Masugi paper we mentioned, and it's looking at one of the most hemodynamically volatile situations we ever have to manage: C-sections in women at high risk for postpartum hemorrhage. We're talking about patients with things like placenta previa or accreta. This is a scenario where massive, rapid blood loss can happen in an instant, and continuous monitoring is absolutely vital. This timeline just beautifully illustrates the story that ClearSight can tell during a C-section. Before the surgery starts, you've got your baseline hemodynamics. Then, at the moment of fetal delivery, bam, there's this dramatic shift. The study showed that the cardiac index peaked right here, while the systemic vascular resistance index, or SVRI, started to fall. That trend continues, and just 5 minutes after the placenta is removed, the CI is still high, but the SVRI hits its absolute lowest point, a drop of nearly 30% from the baseline. This is the classic picture of vasodilation. And then, over the next hour, you can literally watch as the SVRI slowly starts to recover. Being able to see this entire cardiovascular story unfold in real time, beat by beat, and completely non-invasively, well, that provides an incredible depth of insight into the patient's physiology and how they're responding to everything we're doing. All right, now let's switch gears and move to a completely different world, the cardiac surgery suite. Here, our patients often have significant comorbidities. peripheral vascular disease, long-standing hypertension, you name it. Now, these patients will almost always end up with an invasive A-line for the surgery itself. But what's fascinating is that using ClearSight in this setting has revealed some major advantages in terms of operations and safety. I mean, the impact on workflow can be absolutely profound. One study reported that the incredible speed of the ClearSight setup saved up to 3 hours per day in a busy structural heart practice. Think about that. That efficiency gain allowed the team to perform an extra 2 to 3 valve interventions every single day without needing to extend their hours. That is a powerful demonstration of how a simple monitoring choice can directly impact not just hospital efficiency, but actual patient access to care. Let's put some hard numbers on these benefits. That study by Gonson actually timed the setup for both devices in cardiac surgery patients. The average time for ClearSight, just 1.7 minutes. The average time for the invasive arterial line, 5.6 minutes. Now, that might not sound like a huge difference for one case, but it really adds up over a long, busy day. But more importantly, by using a non-invasive method, you completely eliminate the entire spectrum of A-line complications. A large meta-analysis found a temporary arterial occlusion rate of nearly 20% and local infection rates around 0.75%. And while the really serious complications are rare, they are not zero. The ClearSight system brings that procedural risk down to zero. Okay. So we have reviewed the technology, we've picked apart the statistical evidence, and we've looked at the clinical applications. It's time to bring it all together and synthesize everything we've learned into a final balanced verdict. Where does the ClearSight system really belong in our clinical toolkit? So I think the most crucial point here is to see these as complementary technologies, not purely as competitors. On one side, ClearSight's strengths are just undeniable. It is exceptionally safe, it's incredibly fast to get up and running, and it's very easy to use. It gives you this comprehensive picture of hemodynamics, and the evidence is particularly good for the accuracy of its mean arterial pressure and cardiac output. But on the other side, the invasive A-line is the gold standard for a reason. It gives us that direct, unfiltered, real-time pressure data. And, this is the big one, it gives us access for arterial blood gas sampling, which is something ClearSight can simply never do. The A-line has its risks and it's slower, but in many, many cases, it is absolutely indispensable. And we have to be completely honest about the limitations. Let's be really clear about when not to use this. First and foremost, if you even think you're going to need frequent ABGs or any other kind of arterial blood draws, ClearSight is not an alternative to an A-line. Full stop. Second, its accuracy is completely dependent on having adequate peripheral circulation. So in patients with severe peripheral vascular disease, Raynaud's, or maybe those septic shock patients on screaming high doses of vasopressors causing extreme peripheral shutdown, the finger cuff might just not get a reliable signal. And finally, as we saw in the data, while the map accuracy is generally quite good, the accuracy for systolic blood pressure tends to be less reliable, with much wider limits of agreement. That's a really key nuance to remember when you're looking at the monitor. So our final verdict is this. The ClearSight system is not a universal replacement for the invasive arterial line. It just isn't. Instead, I think its greatest value lies in its role as a bridge. It's a bridge to definitive monitoring, letting you get immediate, continuous data in an emergency while you're getting set up for more invasive access. It's a bridge for those intermediate risk patients who clearly need more than an intermittent cuff, but for whom a full A-line might be overkill. It provides rapid, safe, and surprisingly comprehensive hemodynamic assessment when you need it most. And this really brings us to the final question, and it's one I'll leave with you to think about. Just consider your own practice. That trauma patient rolling into the bay, that high-risk obstetric case, or the patient who suddenly becomes unstable during induction. In which of your cases could having access to this kind of immediate, continuous hemodynamic data, literally within 2 minutes, fundamentally change how you manage the case? And maybe, just maybe, change the outcome. Thank you for watching.